Good morning, everyone, and welcome. I'm Sarah Cott, Senior Vice President of Programming at The Hill. Thank you all for joining us in person this morning, and thank you to everyone joining us online as well. Our event today is Science and Policy, the Future of Cancer Care, and I'd like to thank our sponsors, AstraZeneca, for their support of this discussion. The American Cancer Society recently shared a bleak figure. For the first time, the annual number of new cases of cancer in the United States is expected to cross the 2 million mark. While advancements in cancer have led to a steady decline in cancer deaths over the last 30 years, rising cases for many common cancers put that progress at risk. More than 313,000 new breast cancer cases are projected for 2024 alone. How can the federal government, healthcare providers, patients, and other stakeholders working together to promote innovation for cancer prevention and treatment? How should we address inequities when it comes to screening, diagnostics, and cancer care? And how can we reverse the trends of rising cancer incidence in the United States? Now, before we get underway, for everyone in the room, a few housekeeping notes. If you could please turn your phones on silent, that would be greatly appreciated. Thank you. And if you're joining us online, please, you are welcome to join the conversation via social media. You can follow us on Facebook, Instagram, and at the Hill events using the hashtag HillHealth. And then one more note for those of you in the room, you will notice that one of your flyers, the URL at the bottom of it is cut off. We had a little printing error this morning. The URL is saveraretreatments.org. And with that, I'm delighted to welcome Bob Cusack, the Hill's editor-in-chief, to the stage. He will be moderating a special bipartisan interview with Congressman John Joyce and Wiley Nickel, co-sponsors of the Orphan Cures Act.
Hey, Congressman, thanks for joining us.
Good morning.
Want to start with some news of the day. Interesting day in the House yesterday. Speaking of bipartisan, there was a bipartisan vote to basically shelve the motion to vacate. What did you think of that? What was the mood of the House yesterday on that bipartisan vote?
I think there was a clarity that members on both sides of the aisle support Speaker Mike Johnson and want to stay at work and get back to work.
Congressman, your views?
Yeah, I think this was a great message for bipartisan governance. Showing that people here in the House want to get things done, and there's a bipartisan coalition that supports doing the work of the American people, and I think that's a good thing.
Speaking of bipartisanship, tell us about your connection, how you guys work together on legislation that we'll talk about in depth.
Well, two pieces of legislation that Representative Nickel and I work on, the Orphan Cures Act and the Mini Act, address orphan drugs and specifically address orphan diseases. And to be able to collaborate across the aisle, if there's a message that I think resonates with everyone, that cancer doesn't care what your affiliation is. It doesn't care if you're an independent, a Republican, or a Democrat. And to be able to collaborate and address that in a bipartisan manner will allow both of these pieces of legislation to be successful.
Yeah, and in this Congress, if you're going to get anything done, you've got to have bipartisan support. Republicans have a majority in the House, Democrats have a majority in the Senate. We've got the White House, so you have to work together if you want to get anything done. And that's been what's really rewarding about this issue. This is a place where we're continuing to build bipartisan support, and making sure we educate people and get that message out, I think, is really important to the success of it.
What is the path, Congressman Joyce, of the Orphan Cures Act? As I mentioned, it's bipartisan, similar, same amount of Republicans as Democrats or co-sponsors. Looked it up last night. Are you looking to attach this? Have you taught? This has been referred to both Ways and Means and Energy and Healthcare, Energy and Commerce, which is normal for healthcare bills. Can you get this done this year?
I'm an optimist, and I feel that this is so important that the Orphan Cures Act crosses the finish line, whether it's attached to a larger piece of legislation or stands independently. My goal is to see it to be successful. I'd like to set the table for everyone who's listening, who's watching, and who's present here today. This is a piece of legislation that broadens the use of drugs that affect many rare diseases. So we have to define what a rare disease is. A rare disease is a disease that affects 200,000 or fewer Americans. And rare diseases perhaps is a bit of a misnomer, because rare diseases are diseases that we all recognize, like sickle cell disease, like all childhood cancers, like diseases like Duchenne's muscular dystrophy. So maybe rare diseases aren't that rare, that we all know someone who's had a family member or themselves who have had a rare disease, and to be able to attach legislation that has multiple orphan drugs that can be effective against these rare diseases. And so this is a piece of legislation that I think, again, can develop continued bipartisan support and cross the finish line.
No, and I think agree 100%. I think there's a number of larger bills where, as part of the horse trading between the White House, House, and Senate, this is something that should get some attention. And the Inflation Reduction Act was done very hastily. There wasn't a lot of focus on how the work they did in the last Congress could disincentivize the research into these rare diseases. So we're seeing this as just one of the tweaks, tune-ups to the Inflation Reduction Act to help it continue to move forward in a way that's helpful for everyone.
Is that going to be difficult, though, for passage because the Inflation Reduction Act was obviously a partisan bill supported by Democrats but not Republicans, and this is certainly tweaking that legislation, which of course, that law now that the White House is very proud of.
When we do major legislation, we continue to refine it, and I think that's our job in Congress, is to litigate these issues, to have a very robust discussion about how we can improve the Inflation Reduction Act, and I think this is something that, if you care about rare diseases, if you care about fighting cancer, this will help in a very major way.
And what it does is, as we're developing this, we're having bipartisan support. We're moving this forward with Democrats and Republicans sitting down, having these discussions, and signing on to this legislation.
What do you see as a potential vehicle, and do you think it's perhaps more likely after the election in the lame duck session, when sometimes a lot gets done?
I think that whatever the pathway to success is, we're willing to embrace that. Certainly if it occurs during the lame duck session, that would be acceptable as well. Again, we want to see this cross the finish line.
And just to your earlier point about the chaos and confusion we've seen in the House, I think what we saw yesterday with a bipartisan group of legislators, saying we want to move forward is really good for getting legislation done. The last time we did this, we basically lost a month of work in the House, and now we get to focus on, moving legislation forward instead of the standstill that we had the last time this happened.
Congressman, you're a dermatologist, part of the Doctors Caucus. What do you advise people on? We'll talk a lot this morning. There's a lot of work to do on cancer, but we've made a lot of progress. Skin cancer, though, is certainly very prevalent.
Skin cancer in May is Skin Cancer Awareness Month.
Yep.
I would be amiss if I didn't encourage everyone. When we talk about the rising number of cancer cases, protect yourself. Wear your hat, wear your sunglasses, wear a sunscreen of SPF 30 or higher, even on cloudy days between 10 and 4. My grandfather died of skin cancer. I never had the opportunity to meet him. And it was one of the reasons why I became a physician. It's one of the reasons why I became a dermatologist. Skin cancers, when caught early, are some of the most treatable cancers that we have in the United States. We have great opportunities to do that. When I started practicing dermatology, and as recently as before I came to Congress, I practiced derm for 25 years. I practiced with a great partner, my wife, and who continues to practice. I talked to her this morning as she was heading into work, and I was heading into this discussion with you. But 5 years ago, metastatic melanoma was often a death sentence. We knew that. I would see a patient, see a suspicious lesion, excise that, send it for biopsy, palpate for nodes, and if there were nodes, I would send them for a sentinel lymph node biopsy. If those were positive, if it showed that it had already spread from the initial lesion, they were sent for a medical and a surgical evaluation as well. But often, because there were not effective treatments, they were quickly sent to hospice care. But we saw immunotherapies, we saw innovation, which is one of the cornerstones of American medicine. We saw that continue to develop. So now diseases like metastatic melanoma are curable with the treatments that have developed since I came to Congress. Not because of what I did in Congress, but because of the innovation and research that industry continues to do. And those immunotherapies that treat successfully, like President Jimmy Carter, who had metastatic melanoma to the brain, and had that cured because of those immunotherapies. Those immunotherapies then were found to be successful for treating other types of diseases, like squamous cell carcinoma of the lung, another common cancer that we see in the United States. So that multiple drug exemptions, what we're looking for with the Orphan Drug Act is that we remove those drugs that are successful for treating multiple diseases, we remove those from the Medicare price negotiations so that we can continue to see that innovation extend into other arenas. We want to see that innovation, we want to see that investment occur in research and development, and the only way that we can see that being successful is with a minor modification, a minor tweak, if you will, to the IRA.
Congressman Nickel, as far as the Cancer Moonshot Initiative, there's been some frustration from the administration about funding that. And when you look at our rising debt and the future of Medicare, which is not bright, and at some point Congress is going to have to get involved, where are the funding choices going to have to be? Because obviously this is a bipartisan issue, but the debt keeps going higher and higher.
No, we have to do a lot of things at once in Congress. But you get to make your priorities, and I think that's especially important. I'm someone who lost my father to cancer, so this is a huge priority to me. And we have the resources to do it. We need to make those investments, and when we're talking about the Cancer Moonshot, we have the ability to do it, and we just need a continued push and to educate people. That's really the main issue, and what I hope folks here to take to heart is you have an amazing opportunity to educate members of Congress on issues, and if you educate folks on your issues, you're going to be successful here in Washington.
Oh, a question for both of you, Congressman Joyce. First to you. What do you hear back home on healthcare nowadays?
I think that the number one thing that I hear is access to healthcare. I represent South Central Pennsylvania, a rural area, and if there's one positive thing that came out of COVID, it is telemedicine. And extending the access to telemedicine, I work on communications and technology. So as we see the BEADS fund rolling out and expanding the capabilities to have internet connections within my district, that allows those individuals who don't have that access right now to be able to be connected with a specialist. Whether that specialist is in Philadelphia or Pittsburgh, because my district is right in the middle, I want to be able to see that my patients, my constituents, have that ability to connectivity to allow them to have the innovation that allows them to see a specialist much more rapidly without having to travel hours to sit in the waiting room and do that. It's a great opportunity. Patients want that access. Patients want that innovation.
In your district, has broadband really increased the accessibility since COVID?
Without a doubt. I think individuals want that. Once they were able to see how successful that was, they want to be able to have that access. And it occurs specifically in telemedicine.
Congressman, same question to you.
Yeah, I represent a mixture of urban, suburban, and rural. And in the rural parts of my district, access to care is a huge issue. We need to certainly do a lot more. Great strides in the last few years on access to broadband. But in North Carolina, the big issue for us is Medicaid expansion. Finally, after 10 years, we were able to expand Medicaid, and that's a real game changer for rural North Carolina, which is something that we spend a lot of time working on and talking about.
What about the quality of care in districts? You mentioned there's, because healthcare in the United States isn't fair. We have rural, urban issues. We've got a lot of doctors will go to cities. Have you seen improvements there, and anything policymakers can do there?
I'll take that first, because as I ran for office, my district is large. It's 12 counties from Gettysburg out to Somerset counties in South Central and Southwestern Pennsylvania. I ran in a very crowded primary the first time, and I would sit down with folks, and they reached out to hospitals, to pharmacists, to different boards, and say, "You seem like a good guy. It seems like healthcare is your major influence. Probably unlikely you're going to win, but when you're done, here's an application to our hospital." And I left that primary with 12 applications to different hospital facilities. So the first meeting, when we sat down in the office and with my legislative director, Matt Tucker, we developed a plan to bring medical students back to the rural district. Look, I trained in Philadelphia. I trained at Hopkins in Baltimore. I trained at major metropolitan areas. But the ability to return to rural areas is often challenged. Individuals stay typically where they've trained. And so to be able to incentivize students to return to the rural areas, we developed a homegrown healthcare initiative with one of the medical schools in Pennsylvania to allow students to rotate the entirety of their third and fourth year in the rural settings. So we connected with hospitals, we connected with community health centers, and allowed the students to come and rotate there. We involved a Veterans Administration hospital, a VA hospital, to have students there, to have their first exposures. This is not a catch and release program, it's a catch and keep program. And so students develop mentorships. They often return to their homes where they were born, where they have family members that work in these hospitals. First year was 12 students. Second year was 24. Third year was 48. We now have students in residency programs that are committed to stay in these rural areas. And this is predominantly in primary care. This is those individuals who want to be family doctors, who want to be pediatricians and emergency room doctors. If you want to be the next Ben Carson and be a pediatric neurosurgeon, this might not be the best program for you. But if your emphasis is to take care of the individuals in a primary care setting, it's a great opportunity to come home. And we have shown this to be successful, and we have shown this with zero tax dollars being put into these programs. It's sitting down, talking to the hospitals, talking about providing housing for the students, providing meals for the students, and allowing them to come home to central Pennsylvania.
You know, we need to do a lot more for healthcare. For me, I look at it in terms of, you know, rural America. For most parts of rural America, your largest employer is going to be your hospital. In Congress, though, my frustration as a freshman is the amount of different committees that have pieces of this equation. I serve on the House Financial Services Committee, which has some pretty good, pretty good lane where, we've got banking, housing, and Wall Street, so we can really focus on those issues. But one of my hopes as a freshman is we can change how the committees work to just have one health committee where you can get members, like Congressman Joyce, who just focus on everything that touches healthcare in the same committee and really develop that policy expertise.
Along those lines, how do you overcome the bureaucracy of not only Congress, which, as you mentioned, there are a lot of committees that have, I know, I used to cover healthcare, so Energy and Commerce and Ways and Means have a bit of a rivalry. But how do you get over that? And then you have so many government agencies that have their hands in healthcare.
I think you have to embrace that. I think that's the system, and to be able to work in a very calculated method of how you allow each of them to interface to what works the best for your constituents. It's an arduous process. It's not easily achieved. And developing the connections with your fellow colleagues, to be able to work with someone like Representative Nickel, who represents really the research triangle, which is so important to allowing the innovation to continue to occur. When I go home, I talk about his work. I talk about being able to collaborate across the aisle and how important that is for success. But you have to also be able to work within a Veterans Administration hospital that had never seen medical students rotate there. And when we first had our first meeting, it was like we walked out and they said this was unachievable. But the second and the third bite at the apple allows you to find that pathway to success.
Are constituents a little surprised that you have a bipartisan relationship, that bipartisanship
Not at all.
exists?
I think they know my personality. I think that they know that success has to be achieved by working with individuals who have the same goals. And Representative Nickel has those same goals for his constituents that I do.
And part of my frustration with Congress is you have so many people who want to get things done, who are pragmatic, who want to work together, but that's not newsworthy. Nobody covers a plane that lands on time. They cover the plane crashes, which we got to see in some extent yesterday. But the vast majority of the members that I work with are focused on getting things done, and and unfortunately most people just don't get to see that. And
Couple of minutes left. Last question. What's the biggest thing that you worry about in healthcare and combating cancer? One thing that you really wish policymakers got, especially as a doctor?
That we cannot allow the innovation to be stifled. we as legislators need to work together and find that pathway to unleash the investments and the innovation that are truly the cornerstone of American medicine. American patients expect that, and we as legislators have to find that pathway to be able to allow, there are new tests for colon cancer that have been approved and are going to be unleashed, that Americans who are very hesitant to have the screening processes done, the colonoscopies done, can now have a blood test to be able to diagnose early colorectal cancers. It's early diagnosis and treatment that allows for cures. And that's what we will continue to do in the House of Representatives.
And that research part is such a big part of it. My biggest frustration with this issue is we've lost focus on these amazing researchers and the work that's being done to develop the next generation of cures. You get elected to Congress, you get to meet these people who are doing amazing things, and when you start focusing on how we're going to help your grandmother survive, a rare disease, cancer, whatever it is, that really should be the focus. And when we're doing that, we're on much more friendly ground for getting things done and moving legislation through Congress. So that's my biggest frustration, but it's a fixable issue, and we just need to change the focus to that instead.
Well, thank you so much. Please thank the Congressman for joining us this morning. Thank you so much.
And welcome, Mohit.
Thank
you
you,
for
Kathleen.
joining me. We heard some troubling news at the start of the discussion this morning, and that's that cancer rates, after years of declining, are now on the rise. And I know that AstraZeneca has been very, very active in the oncology space. So when you look at what's happening, what are your thoughts on the challenges that the cancer research field faces right now?
Yeah, it's quite shocking to hear that this year we'll cross 2 million mark in terms of number of people diagnosed with cancer here in the United States. I would also pause in the same breath and think about the golden era we are living in, where science, data, technology, research is coming together. And if you think about it, Representative Joyce talked about blood-based screening is coming to life. We have researchers here who are focused on really precision medicine and identifying biomarkers that are able to identify those patients who would benefit more. From multiomics, we are learning so much on the biology of the disease. New modalities with ADCs, gene therapies, cell therapies, radiopharmaceuticals. There's so much happening that I feel very optimistic that actually while we see on this side the numbers increasing, on the other side we see that we are in this, we are at the cusp of solving for these diseases in a many innovative ways. And I look at it and then I think of the work happening here at the Hill and across the ecosystem, and we are able to today talk about Moonshot and being able to say we want to reduce cancer deaths by 50% in the next 25 years, or companies like ours who have been based on this innovation and the work happening in the labs and coming to forefront are able to talk about that we want to eliminate cancer as a cause of death. And we can do that because we see proof points happening on the way. So yes, on one side, it's really shocking to see those numbers go up, and especially in younger populations.
Right.
But on the other side, the hope is there. And I'm also very optimistic, and I tell my 10-year-old what was, what we saw, and we were watching Star Wars the other day, and we were talking about like, hey, this sounded like fiction many years ago, but many things could be possible. And I think the same is happening in the science world. What was fiction, we are seeing with ADCs and gene therapies and cell therapies, that is becoming reality. So there's a lot of hope in that. But I go back to the previous conversation. Like cancer thrives in a tumor microenvironment that creates an ecosystem for cancer to kind of grow faster. Policy is an ecosystem for innovation. Policy is the microenvironment we need to create for that innovation to thrive. And I think as this golden era of science, technology, data, helping us uncover biology of diseases and solve for those rare diseases, we got to really ensure policy goes hands in hand to kind of create that ecosystem for innovation to strive and not be stifled.
Let's talk about that policy. I think we all heard the congressman express their concerns that there are some measures in the Inflation Reduction Act that they believe could potentially stifle rare drug innovation. And I know that when it comes to cancer, that is particularly concerning because 1 in 4 deaths from cancer are from rare cancers.
Yep.
So you are right now on the front lines of innovation, of new drug therapies. What are you seeing when it comes to the impact of the IRA?
Yeah, I think the congressman's view was absolutely spot on. If we rewind back a little bit, and I'll start from where I was talking about innovation and the ecosystem. In 1983, 41 years ago, Congress passed Orphan Drugs Act, right? What they meant, and Joyce explained, an orphan disease or orphan disease is one which has 200,000 or less Americans. So this act helped develop drugs for those or treatments for those kind of patients and those dealing with those diseases, and 650 plus treatments came through that in the last 40 years. We have seen change happen because the incentives were put in the right place. Now, if you think about the Inflation Reduction Act, I think Congress's original intent was to safeguard that because it talked about exclusion of orphan drug from the price negotiation process. But as it was said earlier in the session, it was passed in such a haste. I think it got overlooked that it was all about one orphan designation. Now, those who are in the field of developing innovative therapies or let's say cancer therapies, they will know that you don't know till you try it out and understand the biology and you learn it over the process that, hey, this could actually work in another orphan disease as well. Now the incentives are set against you to not go for that. I'll give you an example. We have a product in our pipeline, a PARP inhibitor, olaparib. In 2014, it got approved in late-line ovarian cancer. So around 300 women would have benefited from that drug.
300 nationwide?
300 in the entire United States. Okay. But then it moved into earlier lines, and that's an orphan disease. So it was able to actually, 2 years back, we showed 7-year overall survivor in those women with ovarian cancer in frontline. So it has drastically changed. At that same time, the trials started, this could actually work in pancreatic, again an orphan disease, right? Now, if you think IRA existed, you would have paused to think about, actually, is it really worth going in there? Are the incentives set right? Not because you won't want to do the right thing. You'll think about what are the competing investments that the same amount could be invested elsewhere to solve for other things that would help drive return to invest back in science, right?
And it costs more, right, to create the rare drugs, these orphan drugs.
Correct, because these are smaller and smaller populations, and it takes bigger trials to run to show the differences. But at the same time, for the same drug, we started a adjuvant breast cancer trial for triple negative women with BRCA mutation. Again, a very small population. It took 8 years for that trial to show that it had 32% reduction in the risk of death. So it is really solving for a huge unmet need for those. And this is a non-orphan. Mm-hmm. So what the representatives today morning were talking about is actually really true, that when you have an orphan drug designation, you want to really take it to other orphan diseases, but also non-orphan diseases. So you really want to look at how do we ensure the incentives continue to support that if you develop one orphan and go to another, that you are not going to be negotiated earlier. Or if actually you found that it could go into a non-orphan disease and help people, then the clock starts later. So the incentives to be set appropriately for following the science and delivering for patients.
Are we actually seeing companies pull drugs from development as a result of the IRA?
Absolutely there are discussions that happen there, and not because you don't want to do the right thing. It's because it's competing with another priority. Yeah. Here you have something that you could develop for a small population. With the same amount, you could develop something to solve for an unmet need for a bigger population. So, you've got those discussions to happen because resources are limited. So I think it's because of IRA you're not putting this in place. It's because the incentives are not set appropriately. And there are reports that talk about, and I caution people, we won't see it today because the drug development process takes years. A decade later, 2 decades later, the Americans who would be facing cancer, instead of we being saying now it's a chronic disease, we can live with cancer and continue our lives, we would see around, and there's a report out there which talks about 139 or 140 less drugs developed for these. And it's going to be 2 decades later or a decade later. So I think the impact is not going to be visible today.
So you're saying it's your children,
Absolutely.
our grandchildren.
Absolutely. And I think that's where we owe to doing things right and really getting around, like having these discussions and putting our efforts around solving for what is going to come. And we saw in the last 2 decades, and we started with mortality had been going down, but incidence is going up. And it's because of the investments in research and the policy and the ecosystem that existed that had that force. We need to continue with that force to ensure that the next 2 decades see improvements in mortality further and potentially eliminating cancer as a cause of death.
So the congressman talked about the Orphan Cures Act. Do you believe that's the best way to rectify the situation?
Yes, I think that is an absolutely a bipartisan support and I think across the industry ecosystem support in terms of solving for what we know is one of the flaws and would get in the way. And I think I encourage people to understand, read that, and really gather support around it. Because at the end of the day, as I said, if we are able to support that innovation system, we'll be able to really bring more diseases, more treatments for these diseases. And it was said in the morning, we talk about rare cancers, but it's not rare. It is not at all rare. And I have personally have dealing with cancer in my family, and I'm sure many people here in this room either have direct friends, family, or are dealing with cancer somehow or the other. And it's going to only increase. And I think we have an opportunity here to solve for those challenges, and those are rare cancers. And I also would go one step forward with the science going further, we understanding the biology more, we're going to get into smaller and smaller populations to have individualized treatment. What is the driver of disease for Mohit, and that we can solve for with a personalized medicine. It's going to get rarer and rarer, but that's the hope that it is going to solve. And we want to put incentives in place, and this would correct what is not today in line with supporting innovation.
Mohit Manrao, Senior Vice President of AstraZeneca and Head of U.S. Oncology. Thank you so much for joining me. Thank you for sharing your passion.
Thank you, Kathleen. Thank you so much.
Danielle, thanks for joining us. It's been a year since we talked. You're a regular at our events.
True?
Yeah, it's been about a year. I watched it last night. It's pretty good.
Good for us.
Yeah, very nice. So when we talked about a year ago, you said, well, listen, we've lost some ground because of COVID in this space. So in the last year, what progress have we made?
Yeah. So the good news is on that in particular, we were talking about the missed screenings, about
Yes.
10 million that happened, especially in the early days of the pandemic. The good news is we are back on track.
Okay.
We are back up to pre-COVID levels of screening by most reports. The President and First Lady put a huge emphasis on this early, and the Reignited Cancer Moonshot as part of this administration. And with private sector actions, we just did an update. I think it went up this morning. Hopefully it's up. That more than 35 organizations and private sector companies made commitments specifically as part of the Moonshot on this issue. And 1 million people had access just based on those commitments. And that's on top of a number of federal government actions, from CDC committing $1 billion to their cancer screening, reaching every state, many tribal organizations and territories. So we've made a lot of progress on that issue in particular. And last month was the the inaugural cancer screening, let me get it right. Cancer Prevention and Early Detection Month. So we're continuing to put a focus here because we know what a difference it makes.
And yes, I mean, but that doesn't happen magically, right? Earlier this year, employers and labor groups also committed to expanding access to cancer screenings. How does that happen? How do you manage the bureaucracy? You got to work with private-public partnerships, but also government, Congress. How does it all work?
I think the good news, and you heard it earlier, is this is an issue everyone cares about. And while I know we're going to talk about innovation in ways to treat cancer while that's important, we know what an impact on reaching the President and First Lady's goal for the Cancer Moonshot of decreasing the cancer death rate by 50%. Prevention and early detection are a huge part of that. They've gotten us to where we are today in the progress we've made in the fight against cancer, and that's how we're going to continue to move forward. So it's an easy sell, is what I'm saying. And that the employer and union commitments were really to say, it's on all of us to take part in this. So all of us to get our recommended screenings, but employers and unions said we want to be a part of it and make sure that our employees have access to the knowledge that they need to know what screenings are available and useful to them, access to the screenings themselves, whether that's time off or bringing the screenings to them. So they've really stepped up as part of this.
You know, I always tell our staff that basically when they're writing a story, there's probably going to be, if they remember one thing from the story, that's a good thing. So as far as screenings, how do you convince people? And I just got a screening, and I learned for the first time that you can get skin cancer by driving, by commuting, and you should wear SPF every day. So I bought that, but how do you make the case to people, stop your busy lives and get your screenings?
It's not just one thing, unfortunately. I think talking about it, which you just did, and sharing that you took this action and it was important and you got ahead of something.
My wife was on me. So
there you go.
There you go, yeah.
Women are often the driver in keeping up with preventative care.
Yes.
But I think it is. It's talking about it and then removing as many barriers as possible. Once we have the knowledge, we're busy, we're taking care of others, we have jobs that might not give time off for this. So working with businesses, working through federal policy to remove as many of those barriers as possible. And I think the other storyline here is the outcomes from cancer are changing, right? A generation ago, 2 generations ago, getting a cancer diagnosis didn't necessarily mean that anything was going to change. Getting it early didn't necessarily mean that anything's going to change. That is not true today. If we detect cancer early for most cancers, many cancers, I'll be safe there, there are treatments that can get people back to their lives or have them live a long time even after a diagnosis.
And as far as that, why is that? Is it just the innovation that we've seen over the last 10, 20 years?
A combination with earlier detection.
Okay.
Right, we now have methods and recommended screening guidelines for many more Americans that are able to catch cancer early when we do have tools that can treat it.
Access to healthcare, when you say cancer screenings, have you seen some of the barriers as far as insurance covering these? Because healthcare is expensive.
Yeah.
Have we made a lot of progress, and where do we need to go on that?
So because of the Affordable Care Act, this was one of the big wins. There's many, I won't go through them all here, but one of the big wins is that preventative services were now covered through all ACA insurance. And so those that are recommended across breast cancer, lung cancer, colorectal cancer, cervical cancer, and others are now covered. So people with insurance should have access to this.
The president has big goals on cancer, and obviously his family's been touched by it. Is his goal of cutting the cancer death rate in half? That's a big goal. Can that be achieved?
It absolutely can be achieved. Like I said, a focus on prevention. We've taken a lot of steps, especially through the Environmental Protection Agency, with the bipartisan infrastructure law, invested billions of dollars in cleaning up toxic Superfund sites and cleaning up our water. We have the first ever drinking water standard for PFAS, so-called forever chemicals that we know have an impact on cancer. We just banned the remaining asbestos product that was previously allowed in the United States. So prevention is going to be a huge part of how we get there. Early detection we've talked about. And then driving more ways for people to access the tools we have, in addition to driving more innovation. One example, the First Lady has shown a lot of leadership here, has been in, for the first time ever, cancer navigation services are reimbursable. So through CMS, CMS put out a new rule, so seniors on Medicare who get a cancer diagnosis can have someone walking them through the steps and the decisions and those barriers to care like travel and financial toxicity that we know have an impact on outcomes. and really change the game. The American Medical Association stepped up as part of that and said, not just for CMS, but for private insurance, we now have codes that reimburse for clinical navigation services. The First Lady brought in 7 heads of insurance companies, and already 150 million Americans covered by those companies have access to this. So we're making progress in making sure that we're driving innovation. We have ARPA-H, we have incredible resources and advances from the National Cancer Institute and the whole innovation ecosystem. But we're really focusing on how do we make sure that that reaches people? Because it doesn't matter what innovations we have if we can't get it to people and they can't access and afford it.
How do we reduce barriers in clinical trials? That's a big issue right now.
Yeah, another one where there's a lot of steps to get there, but we're making progress on many of them. Again, it starts with knowledge and information. And so those navigation services being covered actually impacts this. There's now someone whose time is being respected and paid for to sit with a patient and their family and talk about the next steps. That could open up really important conversations about clinical trials. Another barrier to clinical trials is having data on who would qualify and how to start to do that match. There's great work that started with the 21st Century Cures Act back in 2016. The Office of the National Coordinator for Health IT is having a big meeting out in Bethesda right now that I'm missing to be here. Sorry, guys. But they have been taking steps on having common data elements, agreed upon data that's being entered for every person facing a cancer diagnosis. So now we have a basis of information where we can start to match people even more effectively. And then the third thing is we have to bring care to where people are. And here I mean trials. That barrier that used to exist between care and trials is really kind of getting a little gray and wavy because so many people are accessing, for so many people, the options in trials are better for them because the innovation is moving so quickly. And so we need to make sure that our best cancer hospitals and our community cancer centers have the information, have the ability to help people access those trials.
Speaking of innovation, what is something we didn't talk about a year ago but has exploded since is AI. What are your concerns and maybe hopes for AI? I know a doctor who says AI does a lot of the mundane tasks around the office. He hasn't gotten rid of anybody, but they're able to focus more on the real work as opposed to administrative stuff.
Yeah, I mean, there's been a lot of talk about AI.
Yep.
There's been a lot of talk from the White House about AI. We are very focused on this. The president personally is very focused on this, and my boss, Arthi Prabhakar, has been a leading voice in the administration on this. I think the first thing, and you saw in the AI executive order and other things that came early on, the first focus was let's make sure that we are taking really important steps early on to mitigate the risks that AI can bring to the American people and reduce harm. And a lot of those steps are in progress. As we learn more, as the technology develops, we'll continue to take those steps. But now we get to turn and look at, there's a lot of benefits that can come from this. Think about a public health system that is supported by AI and better reaches people early on in an outbreak or with targeted, culturally appropriate, language-specific information about cancer screenings that the system itself doesn't have the time or capacity or ability to do. But now with AI, maybe we can reach more people with the information we need. All the way through really interesting that some of the former folks up here could talk about even more eloquently, really interesting scientific applications for AI. One project that ARPA-H, the new research agency for health, that's really tackling the things that the rest of the system hasn't figured out yet in new innovative ways, just funded a project focused on rare disease. So what if we took all of the approved drugs at FDA and we were able to look through patent applications and all this information that talks about the specific targets that those drugs target. And now we have someone who, a rare disease organization called EveryCure that has access to information about a number of rare diseases. We could find new matches and new patterns and potentially be able to repurpose something that's already out there for an application for a rare disease that may never have been found because no one was looking.
What about funding for the Cancer Moonshot initiative? What's the future there? There's been some concerns from the administration on that.
Yeah, I mean, the president continues to ask for really robust biomedical research and broad research budgets, including for the Cancer Moonshot. I think the good news is, despite an attempt to undercut and really decrease budgets across the National Institute of Health and the NCI by some on this side of Pennsylvania Avenue, I think the funding for the National Cancer Institute was mostly maintained. That's never good enough, but I think in this sort of budget environment, that is a good first step, and we're going to work to really continue to move it forward. I think the other thing is we have a brand new NCI director who's making really strategic decisions about how to make the best use of what that funding is while maintaining everything that's already going on. And we can't forget that we do have a brand new research agency for health that didn't exist before, that has a good kind of foundation first kickoff funding that's really making a difference.
How many health agencies are there? And how do you manage that?
So the president created the first ever cancer cabinet. And the idea here was we think of the Department of Health and Human Services, right? When we think about the fight against cancer and all of their components, the National Institutes of Health, the NCI under that, the Food and Drug Administration, CMS, CDC. I won't spell them all out. We know what they are. And all of them are a part of it. But I think what's important about the approach that we've taken is that's not enough. Department of Defense, Department of Veterans Affairs has a huge role to play here. The PACT Act that passed in a hugely bipartisan way is making a generational difference in the care that we can provide to veterans who were exposed to toxic substances that can now get access to care for cancer and other diseases. But we didn't stop with those that are focused on health systems. The Environmental Protection Agency and the U.S. Department of Agriculture and the Department of Energy, NASA are all a part of this because we know that it's going to take innovation, like I said, from prevention all the way through survivorship and making sure that Americans have access to those.
What's the thing that excites you most about the future of combating cancer?
Yeah, a few things. Okay. One, we need to finish the job and make sure that we do deliver effective navigation services to all Americans. We've made a great first jump in that, but then I saw a lot of people not even knowing when I was talking about that had happened. And so I think we have a lot more to do to make that real for people. I think the other thing is we have a great opportunity to get really targeted based on risk in our screening and early detection that will make a difference in outcomes. And I'm a scientist. I'm a neuroscientist by training. The innovation in new ways to prevent, detect, and treat this disease are awe-inspiring, right? Like every time I go to a conference, you see that the innovations that were being tried out in small places and showing some promise from the conference the year before are now blossoming into many different types of cancer. And I think that system is moving at a really rapid pace, and we're going to have really interesting, less harmful ways to treat cancer and get people back to their lives.
That must be a rewarding part of your job.
I get to watch the scientists do it now. I'm not in the lab anymore, but yes, it's really, really great to see.
Danielle, thanks so much for joining us.
Thanks for having me.
Appreciate it.
Thank
you.
Thanks.
Hey, great job. Great job. We'll see you next. Memo, let's start with you. Let's go down the line and kind of, I know you've got everyone has a good story that we asked to speak, but if you can kind of introduce yourself and kind of say the connection of why you're here today in your story.
Hi, I'm Mayma Carmel. As of February, I'm an 18 years survivor of triple negative breast cancer. I was diagnosed at 32 years old, found my tumor at 31, and was told that I was too young to have breast cancer. To wait till I was 40 and or 50.
Who told you that?
My doctors.
Very nice. Okay.
My doctor. So my mom's a nurse, fortunately. She taught me breast exams at 13. So I knew my body enough to push for breast, keep pushing. Doctors dismissed me for almost a year. I kept asking for screening. I finally got mammography, came back clean. And I said, well, it can't see what I can feel, so it must be wrong. And they poo-pooed me, but I still kept pushing until I got a biopsy. And thank God I pushed. If I hadn't pushed, I would have been dead years ago. And so Tiger Lily was born as my living legacy, promise to God to ensure that women who looked like me, who were younger at the time, still young, younger and of color, had access to people that looked like us, people that heard us, and that people that saw that we had special challenges and needs to be fulfilled. And so I'm proud to be alive and doing this work every day. We've grown from an org that I created while in chemotherapy to now a national and global organization. So that's what I do every day, help women come out of the fire, pull them out alive.
That's a great story.
So I'm Pam Traxel. I'm with the American Cancer Society Cancer Action Network, which is the public policy arm of the Cancer Society. What I do is really work with patients, much like Mema, and people all across the country to get them to tell their stories to elected officials so that members of Congress and state legislators can really understand what they can do in the fight against cancer. And oftentimes they don't exactly know what that is. So my organization's here to talk to them about the solutions that they can bring to help people live longer and healthier lives with cancer.
Hi, I'm Crystal Denlinger. I'm the CEO of the National Comprehensive Cancer Network, or NCCN. Our organization writes clinical practice guidelines in oncology, which are used all over the world to help clinicians, providers, patients, payers, policymakers understand what appropriate cancer care is. I'm also a GI medical oncologist. I still practice Friday mornings, so I'll go home and practice tomorrow morning. I'm also the daughter of a cancer survivor and someone who passed away from metastatic disease, so cancer is personal to me. And we work as someone who has worked both in the clinical space and now as head of NCCN, we work every day to make sure that we are improving and facilitating quality, effective, equitable, and accessible cancer care for everybody.
Memo, you saw some inequalities, as you mentioned, in the system, and that was in 2006, as I see. What progress have we made since then and in the 18 years since?
We made a lot of progress in terms of, for example, when I first began Tiger Lily, no one saw Black-led groups like me. They were like, you're a patient. There's huge groups, ACS, love y'all, love, but we're friends. But they were like, there's all these groups like Komen, ACS, like they got it, don't worry about it, right? But you cannot underestimate the Black patient perspective and the things that I faced as a woman. My genetics, my husband left after I got diagnosed, became a single mom. There were financial challenges. There were so many things that were happening to me that I had to fight for. And as I began the organization, I kept pushing to be heard. Triple negative breast cancer was not even talked about in 2006, and we didn't get treatments targeting TNBC till 2019, right? And so I think that while there's been progress made, that now I'm still alive. I have an organization that's national and growing, and we train Black women all over the country now in the world. But I still hear patients calling me every day saying that I didn't get listened to. I was dismissed. I was delayed to get diagnosed, and they died. One of my good friends, Shantae, found a lump in her breast at 26 years old as a nurse. She's a nurse. And she was dismissed for 6 years until her nipple was bleeding. And now she's metastatic and she will die. And so I keep hearing these stories, as much as we're doing with the cancer rates and getting more screening, better diagnostics, DE&I is a huge focus now. I still keep hearing these stories. So my thing is, how do we partner with Black-led groups to do the work and fund us to get the work done? So I don't keep having to bury friends every single month. I've gone to one funeral a month for the past 9 months. And last weekend I went to a funeral of my girlfriend Sheila, and she was 15 years metastatic. But the treatments are failing Black patients and many patients of all colors, right? But most of us were dying at twice as rate as women who were white. So I think that while there's been progress made within equity, within policy, within partnerships, I think that we really have to be in the community, not only as a transaction, but as a relationship, and make more investments in time with those communities.
Pam, you mentioned education and educating Congress. How's that going?
It's a process.
Right.
It's a process. I mean, I think for us, when we think about the inequities that Mema talked about, I think one of the things that we realize as the American Cancer Society is that there's so much that Congress can do to help resolve those inequities. And so as I sat and listened to this panel today, and particularly Dr. Carnival and the progress that we made in the Moonshot, she's right. There's more that we can do to access screening earlier, right? And there are still barriers to screening despite the passage of the Affordable Care Act. So 2 of our legislative priorities for this Congress are the PSA Screening for Him Act, which will allow men who are at high risk of prostate cancer to have access to $0 cost sharing for PSA screening. Cost is a real barrier in men getting screened. You mentioned your wife
Yes.
nagging you.
Yes.
Yeah, there's a lot of
So, but if
nagging
there's
that
a big cost, then a lot of men will say, I'm not going for it.
cost is a barrier. Think about it if you had to actually go back to a doctor's office to complete a PSA screening that you didn't want to do in the first place, right? Like there's a challenge there. The second priority we have is the Medicare Multi-Cancer Early Detection Screening Act. So this is a piece of legislation that will create a pathway for coverage for CMS to look at covering these multi-cancer early detection tests once they've been FDA approved and clinical benefit is shown. This is really leaning into where we see the future of cancer screening going and allowing Congress to kind of not just talk about innovation, but create pathways for coverage for innovation so that when these tests are FDA approved and CMS has had their process, that we don't create a disparity in who's able to access those tests.
Crystal, talk about innovation and how do you keep up with the progress, and how do policymakers keep up now with AI, and Congress is talking about regulating AI, and obviously a lot of things are regulated, but there's concern there about going too far.
Yeah, I think that's a great question. And, as both the head of an organization that writes clinical practice guidelines that are updated in real time, as well as someone who on Friday mornings has to sit in front of the patients that I treat, keeping up with the pace of innovation is always a challenge. We are in an era now, and I was thinking about this coming into the panel. 30 years ago, when my dad was diagnosed with cancer, these innovations didn't exist, right? And now, 30 years later, the way in which he was diagnosed and the treatments that he was offered are completely different. And the doctors that treated him, my colleagues back home, need to be able to know exactly what those innovations are at a moment's notice, whether they be at a community cancer center where I grew up or at a big academic cancer center where I practice today. And one of the ways that I think we keep up with innovation is through clinical practice guidelines and utilizing the expertise of those in academia and making sure that we are thinking about how that evidence fits best into everyday practice. It's a challenge for us at the NCCN. We have a large team of staff at headquarters, as well as over 1,900 member institution experts that work on our clinical practice guidelines. They are updated in real time. We had over 200 updates last year based on the pace of innovation. And I think those guidelines and having those guidelines easily accessible, usable, and available for our clinicians and for our patients, patient versions of these, so that everyone is aware of what appropriate care should look like is really important. But it's also a matter of educating the population, educating our policymakers, educating all of the oncology stakeholders that guideline concordant care matters, that it improves outcomes, that guidelines can be very useful in helping to know how to treat someone, but also when to refer someone to maybe a different level of care, or how to incorporate multidisciplinary care or tertiary referral centers in addition to local community care. So I think having resources and knowing where to get the information is really important for everyone involved in the community.
Just to follow up on that, education, this event is about educating people and people watching online and the audience. What are some success stories along those lines to get people, past the acronyms to say, okay, listen, you really, you need to do X, Y, and Z. Cost obviously is a factor, but what are some success stories that you've seen?
Well, I think just the fact that we have developed the clinical practice guidelines, NCCN's clinical practice guidelines, but other organizations as well. ASCO, the American Society of Clinical Oncology, and others do have clinical practice guidelines. And I think making sure that people are aware of those guidelines. And not only that, we've seen that in people who receive guideline concordant care, that they have better outcomes, there are lower disparities, there are lower costs, and there are better quality of life. So making sure that people are aware of them. We know that over 1.8 million people download our guidelines and use our guidelines. There were 15 million downloads last year. I'm sure that across the other professional organizations, there are a number of downloads and users. And I think making sure that everyone across the entire continuum is aware that there are resources available to help define optimal care and that those resources are easily available, accessible, and usable to define it is really important.
Pam, as far as Washington's very focused on Washington, but outside the Washington Beltway, have you seen what success at the state level with different programs that maybe Washington could learn from?
Yeah, we've actually seen probably a lot more success at the state level than we have here in Washington. I don't think that's going to come as a surprise to anybody on the room or online. I think that when we think about cancer, we know that nearly 2 million Americans are going to be diagnosed with cancer, and everyone has a cancer experience. And so that translates into state legislators who are really actively thinking about what they can do to improve cancer care. And that starts with making sure people have access to care, like expanding Medicaid in the 10 states that have not yet expanded Medicaid, because starting your healthcare journey with an insurance card is where it begins. But then it's making sure that throughout that journey that patients have access to screening, whether it be making sure that the National Breast and Cervical Cancer Early Detection Program, which is both state and federal dollars that allow uninsured women to be screened, is funded appropriately. It's making sure that patients, once they're diagnosed with cancer, have access to biomarker testing. So ACSCAN is very pleased to lead some work where right now, if we have some governors do their work, we will have had 19 states pass a law to guarantee patients access to biomarker testing. And this is really where I think we share something in common with NCCN in leaning into the science. We all know that biomarker testing is the future of personalized medicine, and making sure that these laws pass so that patients have access is really where it begins.
So you've seen less polarization at the state level? I mean, obviously you still have some fights.
A lot less polarization. If we think about our key federal priorities or state priorities, they are largely bipartisan priorities. If we look at the Medicare Multi-Cancer Early Detection Act, we have enormous bipartisan support for that bill in both the House and the Senate. And there aren't very many bills that look like that. And that's because cancer doesn't care whether you're a Democrat or a Republican. Cancer doesn't even care if you're registered to vote.
Memo, how do you make the healthcare system more fair? What would you like to either, whether it's legislation or how do you get there?
Well, I think nothing's more powerful than an advocate who knows the facts about cancer, how to advocate for herself, and before she gets sick, when to start being an advocate, right? The problem is we start when people have cancer, right? Not when they're in there getting their annual women's visit. So we worked to train Black women across the country, trained about 400 women, Black women last year to become angel advocates. They learned about the importance of biomarker testing, clinical trials, self-advocacy, how to be a badass in healthcare and do the right things, ask the right questions. So if they're empowered to be involved in policy, clinical trials in the healthcare system, they're now emboldened to go and speak for themselves. And once you realize that you have the power to change your own outcome and someone else's, that power can shift how you engage in these spaces. We've had patients who come to us who say, I wish I found you 6 months before because I've been so lost, so disempowered. Because we've been trained throughout Tiger Lily, we now know how to act. They get to meet people like Pam and people at NCCN and other groups that we bring them together with these partners that make them know that they have the power to change their outcome. And so I think the power is that we have to teach each person that we impact, all of you here, you have the power to change healthcare in a way that's huge. And so using that privilege for power is so important to me, and embodying that in the patients I talk to, that I'm here, but if I have the power to do that work, so can you.
Just to follow up on that, how can healthcare become more human and less transactional?
That's a heavy question.
Yeah.
I mean, I think people have to go back to why they started, right? I mean, why do you all work in healthcare? Because you made an oath to protect people, to keep their hearts beating, to keep them, to see them, to feel them, to hear them. And so I tell doctors that I know that there's a time commitment. You have to be in there 15 minutes and out. You're being tracked by insurance, all of that. But if you treat each person that comes before you like a human being, and you see them and you know their individual needs, that's how you get back to personalized care. It's like, my doctor, when I first met my now doctor, he came in, he was rushing me, and I'm like, can you please stop for a moment? I'm like, what color eyes do I have? They're brown, no, they're black. I'm like, can you hold me? I'm scared. He was like, I can't. Can I do that? I'm like, I want to be touched and held and talked to like a human being. So I tell doctors, you don't forget why you began this work. Don't forget that I'm not the person before me, not number. I'm Mema. That person is Sheila or Shantae or Nani. And so when you relate to the patient as a person, and you know that your actions could either continue or end their heartbeats, the way you treat them is different, right? And so getting back to that human-centered care is critically important.
I would add to what Mima is saying. Like, I oftentimes say to people that, like, well, we can't afford to do this, or you know, it's political, it's so difficult. I'm like, it's not difficult when cancer comes to your own family. And that makes a huge difference. And that's what I say to people. Like, if you haven't had an experience with cancer in your life, you are really, really lucky. I won't review your risks of cancer. You can check out cancer.org, but they're really high. And I think it's different when it's in your family. And that's what I mean, oftentimes when legislators say this can't be a priority for me, I'm like, do you have someone in your family that has cancer? Of course you do. So let's talk about what this means, because that's how you make healthcare more patient-centered.
Yeah, I mean, I don't want anyone to have cancer, but if I could put the fear, the utter terror, the grief, the sadness, all that I've been able to see that we've experienced, Pam, even my body, I never had treatment targeting my cancer because I didn't have treatment for TNBC when I was diagnosed. So I lived in fear for up until like 3 years ago. I was afraid that it was coming from me every day of my life. And I watched my friends who had treatments targeting their cancers dying all the time. And I have a daughter who was 3 when I was diagnosed, and now she's 21. But any little headache, backache, anything, I'm afraid for her. And so I think that if I could bottle up the things that we deal with as cancer patients and the losses and the hurt and the grief and the passion that comes out of that in a bottle and say, drink this, people could actually know what it feels like to be in our bodies, they might do more. But I don't want that for anybody else. But until you experience these disparities, and disparity isn't just black or white, it's about people that didn't get the right, offered biomarker testing or get offered a clinical trial, or who was told that, well, the clinical trial is in New York and you're living in Baltimore and you don't have a car, right? Like, what are you going to do? Your kid has to eat food. You have to pay the bills, right? So I think unless you understand what people are fighting for, people are texting me now for help. I don't sleep. I'm the worst date. I'm like, hold on, honey, text this person back. But when you care that much, it just becomes your life, and it's urgent. People are dying every day.
Can I add, when I think about how to make cancer more human, it's to recognize that cancer comes in the context of the whole person. It's not just, this is the diagnosis and these are the biomarkers and this is the treatment and even this is the algorithm of how you do it. It's what are the health-related social needs that impact this patient's ability to get care? What are the care and support mechanisms that this person has around them? What are the services in the community that might be able to support someone? So it's understanding as an oncologist the full ecosystem in which you practice, as well as the full ecosystem in which your patient and their family lives. I can tell you personally, cancer is not just about the person who is diagnosed with it, it's everyone who is impacted by it. And we talked earlier about the tumor microenvironment. There is also this patient microenvironment, right? The environment in which this patient is supported, in which this disease is now entering. And I think as the oncology community, clinicians, everyone who's thinking about this, policymakers, payers, that we need to be respecting the time and the attention that's necessary to address the whole person that's living with the diagnosis and those around it, not just the tumor itself. And I think that's how you make cancer more human, and that's how you make treating people more human. And you establish the trust that you can talk to someone safely. You can talk to your doctor safely about the issues that are arising. Maybe that you don't have a car to get to that clinical trial in New York, or maybe I really am interested in clinical trials and I will do everything possible because I have a family member who lives in New York who can help me do that. But it's asking the questions on the clinician side. It's also, as patients, recognizing and advocating for all of the components of care that need to be considered. So it's on all sides of the stethoscope, so to speak.
Can I add something quickly? I think too, people have to feel safe, right? As a Black woman living in this country, I know the things I can't do or wear after dark. When I'm in the car, I don't feel safe. So people to me in uniform, for many of our patients, they don't feel safe with people that are in authority, right? And so when you don't feel safe in your Black body in the world, and now you have a cancer disease in your body that is impacting your determinants of health and how you can keep your kids safe and take care of them, and having to go into a healthcare system where you are, maybe told your pain isn't high enough, maybe you're being hypochondriac, maybe all these things people are being told. So if you're not safe in your body or in the world and in healthcare, then how do you feel safe to even adhere to healthcare? When I was getting my treatment, I had a really bad reaction to one of my treatment medications. And they were like, I called the nurse, and I'd be covered in hives from my scalp to my feet, like scratch itching for, I took like 7, 8 Benadryls. And she said, well, nobody else has this side effect. So, I mean, just keep going. I almost quit treatment. And so if I couldn't call my doctor and say I need help and I was going to not adhere to my treatment, I didn't feel safe within that space to say I need help. Can you help me and get that help? Why would I adhere? Why would I go back for support? And so we have patients who maybe one of my other patients, I know we're coming to time, but she was in treatment and her husband left her. She had 3 kids and she ended up being homeless, living in a car. But she was afraid to ask for help because she might lose her kids.
Oh.
So you have to be able to be safe to say, like, I'm going to you and I feel bad. I don't feel good, not get dismissed. But if you have these needs around your housing, around food, around your job, to your point, the patient is a whole person. So when a patient comes to me and they talk to me, and we're done talking, I want them to go like this, like, I feel good. You got me. And that's how I think healthcare can be more human.
Pam, I want to go down the line for each of you on this. We've got a couple of minutes left, so you can take maybe a minute each. But, we have made progress. I talked to older relatives, and they said when they saw the doctor was smoking. You could smoke on a plane back in the day. So those things obviously don't happen anymore. But so what's something that you're very hopeful about? I want to end on a positive note.
I'm hopeful that maybe we have finally reached a time where maybe members of Congress, maybe not all, but some, have really figured out that one of the most important things we need in order to survive serious illness like cancer is health insurance. And I think we were coming out of the pandemic with record high number of insured Americans, and some of that is being undone through Medicaid unwinding. And we obviously have an upcoming expanded subsidy situation with the Affordable Care Act marketplace plans that's coming up. I think we all really need to think about the fact that when you were little, and I'm going to judge this room for a second, your parents might have taken you to the library to get a library card. And remember, it was really special. Like you had to be like, oh, you have to sign your name on the card. And your parents were like trying to teach you how to do that. So this is where you learn for the very first time that cards have power, right? And now today kids are like credit cards. They think it's like free money, right? But imagine what it's like to be a patient like Maima's talking about and to realize that you don't have a health insurance card.
Yeah.
You know right away what a difficult situation you're in. So if we are really going to fulfill the American Cancer Society's mission, which is to end cancer as we know it for everyone, then people need to have health insurance to do that. Because I know all of you are sitting in your chairs and at home thinking like, right, I need a card to go do that. We have to make sure that people have access to healthcare in order to even begin any of this journey.
Crystal, something you're hopeful?
I'm really hopeful about a couple of things. One is innovation. Like I said, I've lived in a cancer world personally over 30 years. The innovation, and I also am a recovering clinical trialist in my prior life before coming to NCCN. And it's been amazing to watch the innovation, to watch us go from a field where we just give cytotoxic therapies that are very general and just kill rapidly dividing cells, to now being able to look at a particular patient, look at the particular subtype of the disease that they have, and be able to potentially match a therapy not only to the biology of their disease, but also to their goals of care. And be able to have discussions that bring all of the stakeholders together to the table. The fact that we're having this discussion, it makes me very hopeful. Because when I started in oncology 20 years ago, now I'm dating myself, I don't think there was as many discussions about the future and innovation and how do you bring that innovation to the patient? Mm-hmm. It was how does the patient come to the innovation? And so the fact that we are now talking about how to increase access to clinical trials, increase diversity of clinical trial enrollment, lower the barriers to get people to the innovation so that where you live doesn't determine whether you have access to innovation is really important. I'm also really just excited about the fact that we have everyone working towards a similar goal, kind of rowing in the same direction, and really thinking about the patient at the heart of that cancer journey and how do we improve patient-centered care and person-centered care. And that may include patient navigation to help those get through care. It may include addressing not just the cancer diagnosis, but those health-related social needs. It may be educating the community through clinical practice guidelines and educational events, educating the policymakers and making sure that they're aware that policies need to be evergreen to keep up with the innovation that's happening on the science side. So I'm really hopeful. I'm an optimist by nature because I'm an oncologist, but I'm really hopeful. And I've already seen a lot of that progress since my dad was diagnosed, and it's amazing to continue to see that grow and to be a part of it.
Mamo, got about a minute left. Something you're hopeful on, looking forward.
In 1 minute.
Yeah, 1 minute. I'm going to hold you to that.
Well, I'm hopeful that when I go into rooms, I'm not the only Black patient in the room, or so often now. Hopeful to see more treatments targeting women's bodies that look like me. We have patients getting involved and enrolled in clinical trials, understanding them. I'm hopeful that Black women know they belong in rooms and their voices are meant to be heard. I'm hopeful that my daughter will never say she ever has say the words "I have cancer" because of all that we all do together and individually. I'm hopeful that I use this quote a lot. I say to my patients, "If I am possible, so are you." So that if I can be a patient that began an organization while in treatment with no money and can now have a global organization, that it's possible for many other Black women and other women of color as well. Hopeful for change in this world. Innovation is growing at faster and faster paces. I was in Austin, Texas, talking about the importance of AI and technology and screening detection. And I just know that progress does take time, right? So we're impatient because it's urgent, people are dying. But there has been so much change, and that patients are embedded in everything that's happening in healthcare now. For me, that's a big deal. And I'm looking forward to seeing more of the same.
We've run out of time. Please thank our great panelists. Hey, thanks so much. Hey, John.
Bob, how are you? Thanks for having me. Of course.
The role of the moderator is not get in the way. So I want to tee up. You've got a phenomenal personal story that was made into a movie, and you have a book. Fire away. What is your story?
So I came into the whole world of biotechnology and medicine the way so many families with cancer also do. We came into it in the world of rare diseases where in 1998, our then 15-month-old daughter, Megan, was diagnosed with a rare form of muscular dystrophy. And, you know, just like in cancer, you go through the shock, the grief, the denial, the anger, all of that. And my wife, Eileen, and I settled on determination, determined to learn everything we could about this rare disease. And it's tough, right? When a doctor says you've got a 15-month-old who's going to be very sick very soon, and I'm sorry, there's nothing we can do. And we also had our 7-day-old son, Patrick, with us at that appointment for the diagnosis. And he said he needs to be tested. There's a 1 in 4 chance he may also have the disease. So no history in our family as a recessive disorder. And that set us into the whole world of medicine. Turns out Patrick also did have Pompe disease. And going from researching in the libraries to trying to find any doctor who knew anything about the disease, to finding a researcher who had an idea for a treatment, who had $30,000 in seed capital and wanted to start a biotech company. So the best he could do for a CEO at the time was me at 32 years old. So we took a home equity loan, started a small biotechnology company, and through the hard work of so many people and the miracle of medicine and grace, we were able to come up with a therapy that saved our children's lives. And they got the therapy late, so they were in wheelchairs, on ventilators. The disease never affects the mind. But fast forward now many years later, Megan is 27 years old, Patrick is 26 years old. Megan ended up graduating from Notre Dame almost 5 years ago and earned her master's in social work at the University of North Carolina and is a social worker at the Make-A-Wish Foundation.
Wow.
So that's, in about 2 minutes, that's about our family journey. The movie's about an hour and 45 minutes. And
I haven't seen it, but I'm going to see it now. Harrison Ford is in it, right?
Yes, Brendan Fraser played me. Yes, which my daughter likes to say is one of the great exaggerations in the history of Hollywood, how they got an actor who's 6'5" to play me. And Harrison was wonderful, was the executive producer, and Kerry Russell played my wife.
Oh, very nice, very nice. Just going to that, what did you learn from that? I imagine it was incredibly frustrating. You said you had to be determined, but there had to be times where you're going through this emotional roller coaster. and you're trying to find answers, and I imagine that was very difficult.
I think probably two lessons, Bob. I think one for us is you can't ever take away hope from people, even in the most desperate of situations. And for us, even literally that first night, I went online with a doctor who was a very good and caring neurologist, told us there was nothing that could be done. I found a paper, before Google even existed, I found an academic research paper showing some researchers at Duke University and then at Rotterdam in the Netherlands working on this disease where they had some promise in early animal models. And I remember waking Eileen up in the middle of the night and kind of rattling off this paper, and she looked at me and she said, asked, what does it mean? And I said, I think it just means that there's hope. And that gave us that small little measure of hope to press forward. I never, frankly, for a long time, I never believed we could change the outcome. I just didn't want to look back years later and have any regrets that we didn't try. And I think the other lesson, importantly, and it's so important in the world of oncology, of course, is to be your advocate, the advocate for yourself, your loved one, your friend, your child, to listen, to learn, to conferences like this that educate, that bring awareness, especially in an area like oncology, where we really are truly at the tip of the spear. And on this golden age of medicine, what I see in my world of biotechnology is this new coming age of biotechnology. With all the technologies we're developing, with personalized medicine where it is, we've never had more hope than we have today. We just need to make sure we don't get in our own way.
And that last point, how do we get in our own way?
Somebody once told me there's nothing in the laws of nature that says that we can't cure every cancer, only in the laws of man. So when I think about, so I'm 2.5 months into this job. And when I started, I laid out my kind of 7 core strategic priorities. And the first was to advance biotechnology as a virtuous circle of innovation. And by that, I mean put the patient, the family member, at the center of everything. But look at what it takes to make newer and better medicines. It takes, academic research, the NIH, it takes the government, it takes small entrepreneurs, large companies, venture capitalists, contract manufacturers. I mean, go along the list. And if you finally get to that point where you get to the top of the circle and you've made a medicine that's meaningfully changed, extended, enhanced somebody's life, very rarely is it a cure. But you've created quality of life and time. Important to that person, and certainly in cancer, but also important to we as innovators and inventors to have time to think about what's next. And that's what we're seeing in oncology. We're just trying to keep ahead. And that's where the sense of urgency is so important. So while innovation, which really just means newer and better medicines and vaccines and therapeutics and quality of care, what it also means is, for me, one of my other priorities is access. Innovation without universal access is insufficient. So let's identify and break down barriers to access. So how do we get in our own way? We heard about the Orphan Cures Act. There are many good pieces of the IRA. That, though, was a mistake put in at the last moment. I've yet to have anybody explain to me the way it's drafted, why it's in there. So we need to fix it. And thankfully, and you heard from Congressman this morning, there's a bipartisan bill to fix that. So that's one. Let's fix that so that we make sure we don't prejudice research, we don't prejudice capital flowing into the rarest of cancers, and we don't put up any artificial barriers to let science tell us where to go. So the Orphan Cures Act is one part of it too. There's also, I don't know if this was a mistake as much as it was an unintended consequence or a misinformed part of the IRA, and that's this artificial distinction between 9 versus 13 years. So if you have a large molecule, a biologic, you get 13 years of protection before you're subject to the IRA pricing mechanisms. If it's a small molecule, you get 9 years of protection. So markets are very rational, and people building these programs are very rational, and you've created this artificial bias in favor of large molecules. What that does is penalize the development of small molecules. It's a disincentive. And that's a shame in cancer especially, where we need these small molecules. We need them, we talk about brain cancer. Oftentimes it's the small molecules that can cross the blood-brain barrier. They are also the medicines most likely to become generic and in the end push down the costs of medicines in the healthcare system. So there's the EPIC Act, bipartisan House and Senate, to address that as well. And I'm hopeful we can have hearings and discussions on that. Let science drive the research, not artificial barriers. And then the last point I'll make is when we talk about access, so many different pieces to it. We've talked about awareness this morning. We've talked about education. But look at the economic disincentives. Look at the insurance system as it's evolved. The whole notion of out-of-pocket expenses, co-pays, co-insurance, deductibles, those were put in place to empower people to manage their health care appropriately, to make informed choices, to have skin in the game. But look at the field of oncology. Who in the world is ever going to take an oncology medicine because there's no out-of-pocket cost? Well, hey, it's free. I think I'll try this. No, not at all. It doesn't work. So let's find a way to do away with out-of-pocket expenses in oncology. Make there be no barriers to patient, no economic barriers. And we have to look at the whole system for how we're going to pay for that. So just a couple of examples of what we could do in the near term so that we don't get in the way of all this remarkable science that's coming forward.
Speaking of that remarkable science, you get to peek behind the curtain. What are you excited about in innovation over the next year, 5 years, 10 years, of things coming down the pike?
Yeah, it really is. When you look at it, again, you get back to that virtuous circle, all the different parts of it, with medicines, of course, playing such an important role, but diagnostics playing the role as well, new surgical techniques and technologies, all with that notion of, okay, we've just given somebody a cancer diagnosis, and the days of, I'm sorry, there's nothing we can do, that's just simply not acceptable. We look at all these technologies that we already have, and those that are in development, and those that we're just starting to think about. Think about, in our field of rare diseases, think about CRISPR technologies, gene editing, the ability to effectively accelerate what might otherwise happen through human evolution. We've got the power to do that now, to do it smartly, to do it ethically. CRISPR didn't exist 12 years ago. It's an invented, so think about what's now in the minds of students and the minds of researchers. We heard earlier that you go in for a cancer diagnosis and you're a person. Almost always the problem solving in medicine and science, and especially in the world of cancer, begins with a person or a family using those 4 words: we have a problem. And a physician or a researcher saying, we have an idea, another 4 words. So when I think about the field of oncology, you look at the moves forward with the CAR T therapies, you look at the immuno-oncology, so you look at the new TIL therapies, you look at the applications of gene therapies, vaccines, mRNA technology, all of it is incredibly exciting. And we have come a long way. In the last 10 years in oncology, we've had 133 new medicines approved, 14 last year. That's good, but it's not enough. And the other important point, too, is when we think about how we modernize clinical trials, the implications for artificial intelligence here are enormous, maybe greater than they are in any other field. We can, I think, in the relatively short term, 5-10 years, revolutionize the entire way that we do clinical trials, obsolete the need for there ever to be placebo controls again, accelerate preclinical research, maybe get to the point where we very rarely, if ever, need animal models. We use it too in the predictions of cancer. Who may have cancer? What's your likelihood? And once you are diagnosed with a cancer at whatever stage, the treatment algorithms are going to be massively impacted by what we do in artificial intelligence. So doing it right, doing it ethically is going to be important as well. But it's something you get excited about. But again, we've got to have it like we had with COVID and the vaccines. We knew we'd get there, but we knew we needed it now. So think about the lessons of COVID. It was, we need safe and effective vaccines. We need to get them to everybody, universal access, and we need it now. So think differently, think bold.
Last question is, and that is a lot to think about and a lot of hope that you have, but what are you most concerned about? It could be a Washington thing, could it be about just the future of healthcare and combating rare diseases and cancers? the polarization, because we've got an aging population, we've got physician shortage already that's only going to get worse. What keeps you up?
You know, there are so many challenges when you get back to the barriers to access, right? So many reasons why we can't do it, why it's so hard. But if you humanize this, and that's part of, so one of my other seven objectives now as the BioCEO is to evolve our communications to center around storytelling. I had the privilege and the honor for several years of serving as the national chairman of the Make-A-Wish Foundation. Our kids were Wish kids when they were young. Make-A-Wish actually started with a young boy named Chris with cancer. Chris Gracious in 1980, acute lymphoblastic leukemia. Back in 1980 was a death sentence for so many children. There was no hope. And he was struggling, and his mom, his doctors knew that he wasn't going to survive. And he told one of his nurses, he said, you know what, when I grow up, I want to be a police officer. And they talked to some friends and cops, and they said, well, we can take him out of the hospital for the day if the docs will allow that.
Right.
And so they did. He had a day where he was strong enough, and he went out. And it was great what the community did for him. He got to ride in the police cars and the helicopters. He got sworn in as an Arizona state trooper. Came home that night, hung up his little uniform they made, and told his mom it was the best day of his life. And Chris died 2 days later. And that's the state of medicine at the time. And that's how the Make-A-Wish Foundation came to be. But fast forward today, the Make-A-Wish Foundation, the majority of kids are not cancer kids because of the miracles of medicine.
Most of them are not.
They are not. They're kids with rare disease, other disorders, so many cancer kids still. But look at where we are with childhood leukemias. You're now to 90+% survival rate for many of the childhood leukemias.
Wow.
Still not enough. We have to go to 100%. But we've come a long way in those years. So those are the barriers where you think about, okay, where are we today? And what hope can we provide? And that's what gets me excited about our role at Bio and my role for kind of being an evangelist for what science and medicine and hope ultimately can do. But let's make sure it's for everybody, and let's make sure we do it as soon as absolutely possible. This has to be our most important priority.
Well, you definitely humanized it with your stories today. John, thank you so much.
Thank you.
Well done.
Thank you.
Thank you, everyone, and that brings us to the end of our program today. Thank you to all our wonderful speakers this morning, and on behalf of The Hill and our sponsors, AstraZeneca, we'd like to thank everyone who joined us here in person and online. If you missed any portion of this discussion, you can find it online at thehill.com. The full event video is available there. And thank you very much, and have a great day.